Do we have everybody in, Micah? Shall we proceed or?
Yes, we can go ahead.
Okay. So, good morning, good afternoon, and good evening, our participants for this very first live session, and welcome on board. And we're happy and excited to have you. Thank you for registering for this online course. So this will be our first live session over the next few months that we will proceed with this course. And this is a course that we previously launched somewhere around July last year, and this is the second version. This is a part of our global primary healthcare support. And my name is Frehiwet. I'm from the International Institute for Primary Healthcare in Ethiopia. I'm currently the acting executive director. So this course will be looking into the way that Ethiopia tried to manage COVID-19 response, especially the perspective of using the health extension program or the community platform. We have on board different experts, both global and national experts, that are going to stay with us for the next 1 hour. So we're very excited and welcome to this live session. Over to you, Micah.
Thank you, Dr. Freywat, and welcome to all of you. It's wonderful to see such a great turnout. We're excited for an exciting and animated discussion in the second part of the session. So I think we have a few introductory slides that I think the team at IFPHC is going to take us through to show who contributed to the course and a little bit of a few housekeeping things. So I think we should go with that. It's just incredibly exciting to see this course move forward and see the interest from all of you and all of the leadership and really exciting contributions from both the Institute and from the collaboration with the Ministry of Health in Ethiopia as well. So I think we should jump ahead and go through a few slides, and then we'll have an exciting panel of speakers to introduce in a few minutes as well. So thank you very much, everyone, and back to you, Dr. Freywat, and I'll manage the slides from this side, so just let me know how to proceed.
Okay. Thank you, Micah. Yeah, so our course logistics will be about faculty introduction. We'll introduce you to experts who have contributed to this course. We'll give you a little bit information about the course and the course importance, and we will have a few points about site navigation. And there will be, experts presenting on global PHC principles and the extension program. Next slide, please. Micah, next slide.
And we're having some technical difficulties here. Give us 1 second.
Okay.
I'm not sure why the slides aren't moving. Let's try resharing them for a second here. All right, is that better?
Yes. So, okay, great. So the course faculty members is the first one that you see is myself, and we have Dr. Micah Schleif, who is from Johns Hopkins School of Public Health. She also contributed to this course. She is an assistant scientist at the Johns Hopkins University. Next slide, please. Oh, you're still having troubles?
Yeah, so I'm not sure why.
We can share it from our end.
Okay, if you all have it ready, that would be great. Sorry about that.
Can everybody see this? Micah, is it visible?
Yep.
Okay. So we have expert contributors. On the first part, you see Tersit Mohari. She is the Assistant Program Coordinator at the International Institute for Primary Healthcare, Ethiopia. She's also leading the course development and facilitation from our end. We have Bruh Alamno. He is our online training manager at the institute as well. So I think most of you met him virtually. He has been communicating you and reaching out for most of the platform related issues and introducing the course. I think we're facing the same trouble you're facing, Micah. Sure. We would like to apologize. We're having some technical difficulties in sharing the PowerPoint slides. Micah, can you try to? Okay. They consider. Okay. Can you see this, Micah? We're trying to.
That works.
Okay, great. So we have Dr. Mizan Kiros. He is currently the National COVID-19 Response Task Force Coordinator and advisor to the Minister at the Ethiopian Ministry of Health. We have Dr. Wendesan Shatu, who is the Senior Program Advisor for the COVID-19 Task Force at the State Minister's Office at the Ministry of Health. We also have Tamasgen Ayo, who is the former Director of Health Extension Program in Primary Healthcare in Ethiopia. You might have seen the two expert contributors if you have joined our first version. We have Dr. Samuel Zemenfes Kudus, who is the former Deputy Director at the Addis Ababa Regional Health Bureau. We have Dr. Bayana Moges, the former Senior Advisor to Public Health Emergency Management to the Minister and the International Institute for Primary Healthcare. We also have Professor Henry Perry from Johns Hopkins Bloomberg School of Public Health. He's a senior scientist there. He's also with us today in the live session. The goal of this course is for our learners to gain knowledge and skill that's related to primary healthcare and in the response for outbreaks and other emergency situations. We will have opportunities to adopt content from the course, especially from the experiences that we try to incorporate like the Ethiopian experience, and you'll be able to learn directly from leaders and global experts in the PHC arena, as well as in the COVID-19 response management, as you have seen from the previous slide decks. The learning objectives of this course are describe the fundamental principles of PHC, of course, since it's a primary healthcare related course, explain the structures and major functions of the Ethiopian Health Extension Program. We will also examine ways in which the COVID-19 response in Ethiopia has engaged the community part of it, which is the health extension program, and vice versa. We will see how the HEP contributed to the COVID-19 response, and as well as what the opportunities are on the ground to continue the response as we move forward in the recovery period. We will also critique the COVID-19 response, and participants will be able to actually do that, critiquing the COVID-19 response in their own context, and determine additional opportunities for integrating this pandemic response effort with the existing primary healthcare structures. So Bruch will walk us through about the site navigation. So I'm going to hand it over to Bruch.
So thank you, Mr. Prayot. I will just highlight some features that are very important to navigate through our Moodle platform. This is based on the participants who asked me to show them some features of our Moodle platform. So I'm sharing my screen. I think now you can see my screen. Is that right?
That's correct.
So very good. The first thing that I want to show you is how to reset your password if you suddenly forget a password to your user at this platform. So you can reset your password by clicking over here, forgot password icon, so that you can reset your password by your own. Otherwise, you can email us anytime to have that access from our side, so that we can reset your password and give you access again. This is the first thing. And the other, after you log in, your course will be in your entry page, so that you can click on the course and navigate all the contents. While navigating all the contents, I want to remind you some very important things that makes you eligible for certification and also makes you to get almost all pertinent contents of the course. So as an example, in module 1, in module 2, section 1, you can see here, the first section is for the reading section. So modules, that means the core contents of each section or each module are there. So you should read those PDFs by downloading it, or you can read online on our system. The other is the videos that were made by interviewing higher experts in the real environment here. So you should see, or you should download and save and later on see those videos. You can also download the supplemental readings. These are not required contents for this course, but you can download them and store it for your later use. The other thing that you should or you must do is reflecting to the forum, the questions in the forums in each section. And finally, you should also answer to the cues in each section or each module, so that you can score, you should score about 75% and above to pass that quiz. Otherwise, you have almost 5 attempts that you can reattempt the quiz. And finally, in each module, we set a task list that should be completed before proceeding to the next action. That's a checkpoint for you, so that you should check these pointers to check your completion of that section. So as you see in my screen, while checking each section, the percent of completion gets to 100, so that we will know that you completed each section accordingly, so that you will be eligible for certification. And for people in Ethiopia, this course will have a few pointers, so that you should complete all these checkpointers accordingly. Thank you.
We're back with my next agenda on the table. So I would like to introduce Ato Wendesan Nagatu from the Health Extension Program and Primary Healthcare Directorate at the Ministry to talk about the Health Extension Program in Ethiopia. So over to you, Wendesan. So we're trying to share a screen, so be patient with us.
Good afternoon, everyone. Thank you, Dr. Frey. I'm going to give you a highlight on the Ethiopian primary health care. In Ethiopia, the health service is structured in three tier system, which is, as you can see here, the primary level health care, the secondary level, and the tertiary level. So for today, our focus will be the primary health care level. And the primary health care level has three kinds of service points, as you can see from the slide. There's the posters. There's post is staffed with 12 extension workers, and are responsible for serving about 3 to 5,000 people. And their centers, having an average of 20 staff, will serve between 25 to 40,000 population. The rural health centers are expected to serve for about 25,000, and the urban ones are expected to serve for 40,000 people. And the third one is primary hospital, having inpatient and ambulatory service, and service about 100,000 people. So the 5 health posters, satellite health posters, health center, and a primary health hospital, we call them primary health care unit. And the primary health care unit is expected to serve for about 100,000 people. When we come to the health extension program, it is an innovative service and targets a household and focuses on the promotive, preventive, and basic curative health services. And it has a defined package of basic and essential promotive, preventive, and some curative health services. And as I said earlier, it targets householders. And the health extension program is adopted with a view of achieving universal health coverage of the primary health care to the rural population. When we see the need of health extension program in Ethiopia, the main reasons to design the health extension program in Ethiopia is a high disease burden of communicable disease, limited utilization of healthcare services, which is related to the low literacy, health literacy, and low health system literacy, and weak community involvement in health services. The need for high-level hygiene and sanitation is very demanding, and there is a weak communication strategy to reach out the people at the grassroots level. These are the main reasons to design the health extension program in Ethiopia. And when we see the philosophy and the goal of the health extension program, the philosophy is if the right knowledge and skill is transferred to the householders, they can take their responsibility for producing and maintaining their own health. And having this philosophy, the health extension program is designed with an overall goal of creating a healthy society and reducing the rates of maternal and child morbidity and mortality. When we see the objectives of the health extension program, the overall objective is to provide equitable, promotive, preventive, and basic curative health services to the community targeting householders. And it has also specific objectives. The first one is to enable the community produce their own health by themselves and strengthen the health promotion and disease prevention activities by improving the health literacy of the community, improve the maternal and child health, avail quality and universal coverage of basic health service, and finally strengthen the referral system at all levels. These are the main specific objectives of expanding and implementing the health extension program in the Ethiopian health system. Whilst we see the implementation strategies of the health extension program, the main strategy, one of the main strategies, improving the community participation or community engagement. In our setup, we do have a community engagement platform, which we call the Health Development Army or Women Development Army. So the community participation is crucial in implementing the health extension program. So this is one of the implementing strategy, and the other is the other is strengthening the primary health care unit, or the linkage between the health center and health post. So we consider the health post is one of the extended arm of health center. In our situation, health center have on average 5 satellite health posts under it, and referral linkage or the health post and health center linkage is one of the critical implementation strategy in implementing the health extension program. The other is intersectoral collaboration and partnership, and continuous in-service training and professional development for the health extension programs. These are the implementation strategies of the health extension program. The health extension programs have different components, about 5 components. The first one is the family health component. This also contains 5 packages. And the second one is health education and communication. This is the second component of the health extension program. The third is hygiene and environmental health, which contains about 7 packages. And the last component is disease prevention and control, which also comprised of 5 health extension program packages. When we see the detailed package of each components, the hygiene and environmental health contains the personal hygiene, water and sanitation, food hygiene, latrine, solid and liquid waste disposal, housing, construction, and insects and rodents control. These are the 7 packages which are organized under the hygiene and environmental health component. The next is the disease prevention and control. It focuses on prevention of HIV and TB, malaria, first aid, non-communicable disease, and mental health as well. That's the latter, the 2, NCD and mental health are the package which are added recently. And the other, the family health component contains the maternal and child health package, family planning, immunization, nutrition, adolescent health. These are the components under the family health. And the health education by itself is a component and one of the 18 packages among the health extension program. I think this is enough to give you a highlight on the Ethiopian health extension program and to initiate our discussion. If you have any comments and ideas, we'll have a discussion session and we'll come back.
Okay.
Thank you.
Thank you, Wendasan. I think we have good insight about the Ethiopian Health Extension Program, and we were also monitoring the chat boxes, and we saw a couple of comments about other countries' structure, and this is what we want as an output from this training, to be able to share different experiences, not only Ethiopia's, but we want to hear from participants outside of Ethiopia. With that being said, I would like to hand it over to Micah for the next presentation.
Thank you very much, Dr. Frewold, and thank you, Juan Rosten, as well, for that excellent overview of the Health Extension Program. So now it is a great privilege to introduce a mentor and friend of mine, Dr. Henry Perry, who's been involved with this work in Ethiopia for a long while and has really spent his entire career working on advocating for and implementing and evaluating community health and primary healthcare programs around the world. So Henry's here today to share a few words about some reflections and some sort of advice or suggestions about where we're heading in terms of primary healthcare in the coming years, and just share a few reflections from all of his vast experience. So welcome to Henry. Thank you for being with us this morning, and over to you.
Thank you very much, Micah, and greetings everyone. It's a great pleasure to be here. What I want to focus, a few comments that I have now are on how the COVID-19 pandemic has affected the community health movement, and particularly the movement towards a stronger role for community health workers throughout the world. I've been working in this area for a long time, and it's been an uphill battle. Community health and community health workers have received short shrift, haven't received the kind of recognition and importance that I knew for a long time they should have. In fact, at various points in my career and frustration, I used to say that community health workers are an underfunded afterthought. And I even found myself saying that in the minds of many people, community health workers are a second-class solution to a temporary problem. And I said that because a lot of people thought that, and still think that community health workers really can't provide high quality care, and that they're only needed on a temporary basis because once the high burden of disease from maternal and child health conditions and communicable diseases goes away, then we won't need community health workers. Well, in my view, the COVID pandemic, in spite of its terrible effects on illness and loss of life and economic devastation throughout the world, in spite of those things, the silver lining of the cloud of COVID, at least one of the silver linings from my viewpoint, is that the role of community health workers has become much stronger now. People appreciate the fact that we need an on-the-ground worker to be engaged in basic and essential services and to be able to respond to the COVID-19 pandemic, and not only to play a role in our current crisis, but to be there for the future, because all the experts tell us that the COVID-19 pandemic is only the beginning of further pandemics on down the road. And so if we're going to be prepared for dealing with these future pandemics, as well as responding to the current pandemic, we need a strong community health worker system, not only in poor countries, but in developed countries too. So there has been for a long time in the United States a movement, although it's been small, to bring a stronger role for community health workers. And the number of community health workers in the United States has been growing rapidly over the past few years. And as a response to the COVID pandemic in the United States, our President Joseph Biden has provided leadership for our government to make a massive investment now in the public health workforce. And that's to the tune of $7 billion, which will be spent over the next few years. And an important part of that is funding for something on the order of 100,000 community health workers. And these are envisioned not only as a temporary stopgap solution, but they are envisioned to be a long-term member of our healthcare system and public health workforce. And this is a major step forward for the community health worker movement, because it's a message to the world that we will continue to need these people no matter how well developed our health system becomes. And it's a message that says that even in the rich countries, we still need people like this to carry out basic and essential functions. And the economic devastation of the COVID-19 pandemic means that whatever we can do to limit the economic impact of future pandemics will be a worthy investment working towards the future. And so the financial argument for providing support that community health workers need has become very strong now in the face of the COVID-19 pandemic. I wanted to share a few thoughts about some of the things that have been happening in other countries that are not high income countries, but are countries in the developing world, and what has happened with respect to community health workers in the COVID pandemic. So I think all of us are aware that community health workers have been called into action in so many different ways. And I hope that some of you can share a little bit about your own countries and what has happened there if we have time and we get into the discussion. But there are just a couple of things I wanted to mention. One is that there's been recently published a review of the contribution of community health workers to the COVID pandemic in Southeast Asia. And there has been a very strong response in all of these countries in employing community health workers to raise awareness about COVID issues, to promote the appropriate behavioral changes that we need: social distancing, hand washing, and face masks, assistance with surveillance and contact tracing, and further following the isolation and quarantine guidelines that exist for COVID. All of these have been important roles for community health workers in Southeast Asia, according to this recently published article. And I'm sure it's true not only there, but virtually all countries around the world. But an even more perhaps important role that community health workers have played is that they have continued to provide essential services and provide continuity for those services. It's been widely stated that there'll probably be more people who will die from lack of access to basic and essential services that have been cut back because of the COVID pandemic than the actual number of people who die from the COVID infection itself. So whatever we can do to continue the provision of basic and essential services is so important right now, and also as we look toward the future of dealing with future pandemics. But of course, community health workers have faced many challenges in doing this. Many have felt that they haven't received the proper recognition and the incentives and remuneration that they feel they deserve in the face of this very difficult challenge. A lot of them haven't been adequately trained, and a lot of them haven't had appropriate protective, personal protective equipment. And then there's been a stigma associated with doing this kind of work that community health workers have had to face. In light of all of these, there is a very exciting article that is just about to come out in The Lancet that's led by some of the champions of community health workers in an organization called the Community Health Impact Coalition, led by Margaret Ballard. And they have a number of organizations that are part of their Community Health Impact Coalition that are NGOs providing community-based primary healthcare services, and they have promoted a model of what they call the professionalized community health worker who is well paid and well supported. And they have just reported the results of their analysis of the work of these I think 24 different NGOs using these well-supported community health workers, and they've been able to demonstrate that in the face of the pandemic in 4 African countries, the use of these community health workers has made it possible to continue basic and essential services at the household level without diminution of services, whether it's home visitation, management of acute and important childhood illness, postpartum care, and so forth. As we look toward the future in the face of all of this, I think it's safe to say that community health workers are going to be playing an increasingly important role. And this is particularly true for the COVID immunization campaign that is just now getting underway. This will be the biggest immunization campaign in the history of the world. And there has been so much experience now with community health workers facilitating immunization programs, providing immunizations, and they are beginning to play an important role in this. And I'm sure that over the next months and few years that they will come to the forefront in their importance in making this immunization campaign a success. It's obvious that we are going to need well-supported and well-paid community health workers that are an integral part of the health system. So this is another theme that has come up, the need to have these community health workers more closely connected to the health system itself. And the importance of creating a health system that can continue to provide basic and essential services in the face of future pandemics, and who knows what other crises will arise, whether there'll be political problems or humanitarian disasters or climate events. So building a more resilient health system will increasingly require a strong foundation of community health workers. The article from Margaret Ballard and her colleagues that will be coming out in the Lancet in just a few days concludes with this thought. Community health workers who were equipped and prepared for the pandemic were able to maintain speed and coverage of community delivered care during the pandemic period. Given that the majority of community health workers globally remained unpaid and largely unsupported, this paper suggests that the opportunity cost of not professionalizing community health workers may be larger than previously estimated, particularly in light of the inevitability of future pandemics. So as someone who's been working for a half century now on community health and community health workers, to me, this is an exciting moment in the whole evolution of this process. And the COVID pandemic has helped, but it's not the only factor, but it certainly helped to move the community health worker movement into what I call the dawn of a new era, in which we will increasingly provide these essential workers with the kind of training and support and integration with the health system that they need to achieve their full potential. So thank you very much, and it's been a great privilege for me to be a small part of this. Thank you.
Thank you, Professor Henry. It was a pleasure having you on board as well, and thank you for this wonderful insights and perspectives, related with COVID-19 and community health program. So I'm just gonna go ahead and introduce our next speaker. If you have questions, please make sure that you're holding on to your thoughts. Drop us your questions in the chat box so that we can address them. The last speaker is going to be Dr. Iskender Wolka from the International Institute for Primary Healthcare in Ethiopia. So he'll be taking a few minutes to say a few words about the primary healthcare and health extension program and other perspectives as well. So over to you, Dr. Iskender.
Thank you so much, Dr. Frey. Of course, I will take a few minutes because most of the health extension program and the primary healthcare system of Ethiopia is covered by my colleague Wonderson. And to add a few things, just based on the presentation from Wonderson, currently this health extension program, particularly we can consider these health extension workers as community health workers in our context. And there are more than 17,000 health extension health posts every Kavale. Kavale means it is the smallest administrative unit in our context, Ethiopian context. And almost every Kavale has this health post. And again, more than 39,000 health extension workers deployed to provide services mentioned by Wonderson, family health related package, disease prevention and the control related package, and again, hygiene, environmental sanitation, and the health education programs. And maybe in the recent development, to add one point about the recent development of health extension program currently, in 2019, National Health Extension program evaluation was conducted to fit this program into different changes, like there are socio-economic changes, again, there are epidemiologic transitions, again, there are some demands, particularly from community side. The community is more demanding curative services in addition to these preventive and the promotive services, because in previous times more focus is given for preventive and the promotive services, but because of the demand from community side, just considering these points, it's some findings based on the national health extension program assessment and the roadmap currently launched for next 15 years, and this roadmap is focusing by or correcting some very important issues that are identified by National Health Extension Program assessment, and particularly just to point some very few, like stratification of health posts for different categories, changing some professional mix, even deploying some different health cadres in these health posts, rethinking of some community engagement strategies, and again, ensure or how we can make this health extension program is resilient for some situations like emergency, like COVID-19. So focusing this point is, again, there is some revision, and this new roadmap is launched to add this point. Again, most of the issues addressed by Wonderson, and thank you very much, Ray.
So thank you, Dr. Iskender, for those important points. So I think we can directly proceed to entertaining questions and comments. I just see a couple of them directed to the health extension program. So we can address, but if you want to speak as well, feel free to raise your hand and we'll be able to admit you. So the first question will be to Wonderson, and then it says, health extension workers are responsible to managing too many packages, and do you think they can manage every activity as per the plan?
Okay. Thank you. The question is right. As I tried to present, the health extension workers are responsible in implementing those mentioned health extension program package. Of course, the package seems many, and the number of health extension workers assigned per couple is about 2. To minimize the burden to the health extension workers, there is a community engagement platform that I mentioned in the presentation, the so-called Women Development Army or the Health Development Army. So they are recruited by the health extension workers and the Kabbalah administration, and they are trained on the health extension package, on the all health extension package. And after they took the train, they liaise the community with the health extension workers, and they are supported by the community engagement platform. And the other thing is the health center, the supervising health center for the health posters are also responsible in supporting the implementation of the health extension program package. Even though it seems many packages, they are supported by the health center as well as the community health workers platform. And are so far for the last 16 years, they are working on the health extension package and trying to address many health issues. And there are also many improvements in the community, like reducing the maternal and child mortality, and the improvement of the hygiene and sanitation program. And like these are some of the main improvements that the extension workers try to address in the community. So for the future, as Dr. Iskandar mentioned, we are optimizing the health extension program, and there will be different categories of health posts based on their distance from the supervising health center. And we will have a comprehensive and basic health posts, and the comprehensive health posts will be equipped with different disciplines of professions, like the health extension worker, health officer, midwife, and the nurse as well. So there will be a task sharing in the situation, and they will get a bit relief in doing so. And the other thing, we will strengthen the community engagement platform, and those who are working closely with the health extension workers will be empowered, and they will help in implementing the package.
Okay, thank you, Wandasa.
Yeah, thank you so much, Wandwasan. It looks like the next question is for Dr. Perry. So the question is from Kamalia, and she's asking an interesting question. So if the dawn of a new era is to see professional community health workers who are well-trained and well-paid, then what's the difference between them and other members of the health workforce, such as, for example, community nurses? So love your perspective on that, Henry.
Okay, great. Thank you very much. That's a wonderful question. Community health workers obviously can't exist in isolation. They need to be supported by the primary healthcare system in all countries in which they work. And they need to be supervised, and they need to be connected to higher levels of workers in the community-based primary healthcare system, as well as in the facility-based primary healthcare system. So to provide the proper kind of strong community health worker programs we need requires not only investing in them themselves, but the support they need. And one of these, of course, is supervision, which has been always one of the weak components of community health worker programs throughout the world. And we need higher level staff, community health nurses and graduate nurses who can provide care for more complicated patients and can provide support and supervision for community health workers. These are all essential. We're going to see a lot of interesting changes, I think, in the roles of community health workers in the way in which they work. One of the evolutions that I see happening in a number of places in Ethiopia is a great example, and that is the creation of what I call dual cadres of community health worker programs, in which we have a professionalized community health worker who's well-trained, adequately supported with the salary and other support, who works full-time and has 6 to 12 months of training. In the Ethiopian case, they have 1 year of training. but they work with a much larger number of volunteer community health workers who each have a much smaller number of households. So in the Ethiopian case, the health extension worker has 2,500 people roughly for which she is responsible. And then you have the volunteer health development army who each have 5 to 10 households. That's just one example. So we're going to see that kind of evolution. And as the responsibilities of these people increase, then they'll only be able to serve a smaller number, or we'll probably have some specialization of these workers as well to some degree, and it'll vary from place to place. So frontline health workers are increasingly recognized as being essential for strengthening primary health care, and they will need to be strengthened in order to strengthen community health worker programs. I hope that's helpful. Thanks.
Thank you, Professor Henry. I think that was a wonderful insight, especially considering the future. We have a couple of more questions in our chat box for the health extension program, and I will directly address this to Wendosen. The first one is, what's the challenge related to HEP implementation? And also, if you have considered, if there are any curriculum-related incorporations, especially with COVID-19, both pre and post deployment for the health extension program. So there was also one question related to that when health extension workers are inclined to clinical package, the health extension's response to the hygiene and environmental sanitation component gets less attention. So what's the strategy to actually improve those? So we'll try to manage our time in responding to your questions. If not, we will be able to address it in the discussion forum. So I will give the floor to Wendosen.
Okay, thank you, Dr. Frey. I think the challenges, we have also many challenges. Among those challenges, one of the challenges is the turnover of health extension workers and the weak intersectoral collaboration, and sometimes the weakness of the community engagement platform. These are some of the challenges that we have been facing regarding implementing the health extension program. And regarding COVID, including in the curriculum, so far we are not working on that, but since the outbreak of COVID in our country, we have been capacitating the health extension workers through different platforms. One of the platforms that we were using is the simple mobile-based training. So so far, as of last week, we have to try to reach out about 25,000 health extension workers for training of basic COVID message to transmit the message to the community and utilize it for themselves. So we'll think we'll discuss on it in our team to include it in the curriculum, whether it is feasible or not. And the other question that raised is the health extension workers are inclined to the clinical service. As far as I know, they are basically working on the health promotion and some curative services for especially the child health, NSI activities. So we are supporting and working to balance the prevention as well as the curative service. Therefore, basically, most of the health extension workers spend their time to the home visit and working on the awareness creation of the community in preventing different diseases, especially which arise from the poor hygiene and environmental sanitation. So if there is a gap regarding to promoting the hygiene and environmental health aspects. We'll try to work with the Hygiene and Environmental Health Directorate and try to optimize the prevention part as well. Thank you.
Okay, thank you, Wenderson. Micah, how are we doing with time? I think we have a couple of minutes remaining to finalize our sessions. Our session, we see a couple of questions coming our way, but we'll make sure that those are addressed in our discussion forum and platforms. Our experts can respond to your requests, and we will be happy to address those and connect these questions to actual experts who were in the live session today. We also be able to answer some of your questions if you go to the next modules, especially if they're COVID related. We have experts who have been, involved hands-on in the national response. We will be getting perspectives from other organizations like AMREF, not only in Ethiopia, but in other countries as well. We will also get the perspective from World Health Organization Regional Office to incorporate some of the best experiences and the lessons learned, and as well as the challenge. So I'm gonna hand it to you, Micah, if you have a couple of points to say, and then we can finalize our session. Thank you.
Thank you, Dr. Freewold, and thank you to our wonderful panel for all of your expertise and perspectives and suggestions for the future and all the work that you're doing. We have come to the end of our time. I know these sessions always go very quickly, but we will make sure that the questions that just came in here at the end are addressed through the discussion board, and or if any of the panelists want to type any responses in the chat while we're closing the session, that's also great. And if you have further questions that we didn't even get to today, or if they come up as you continue through the modules, as Dr. Freewold also suggested, there's a lot more content to come. There will be 2 more live sessions that we'll be announcing in the coming days with more information, with some additional partners and guest speakers from across the African region. So very excited about that, and hope you'll be able to join for those sessions as well. We will be posting the recording from this session on the course platform, as well as a copy of the slides. So you can refer back to them, and it's just really exciting to see all of you here and to hear the great questions and everything. So thank you again to the panel, and thank you to the team at the Institute for all of the hard work to make this session come together. So wish you all an excellent rest of the evening or day, wherever you're based, and just want to hand back to Dr. Freewold in case there's anything else you want to say in closing.
I think everything has been said. We were really excited to have you on board, and thank you for those insightful questions, and the discussion was fantastic, and we would like to keep our engagement with you. I'm sure most of you have registered to our course, but if you have not, please go to our link and register to this course, because we have interesting sessions coming up. And we would also like to make one last announcement. The second and third session of sections of the module 2 will be released after this call, so stay tuned, and thank you everyone for joining us. Have a great remaining time of your day, whether it's morning, evening, or afternoon. Thank you everyone.